Hello, my name is Lloyd Hay, and this is a brief talk on adult spinal deformity. I want to thank Tom Turner, my research assistant, for his help not only with this talk, but our recent book chapter for Up to Date. And also thanks to my colleagues at the Scoliosis Research Society that have been working on through the Adult Deformity Committee for helping prepare various writings for our SRS website to help physicians of all types and mid-levels to know how to handle patients with spinal deformity. The main take-home message for this lecture is that all of us as providers should be asking more about scoliosis and kyphosis histories and be concerned about ways that we can maintain and improve quality of life for these patients, preventing problems before they happen. There are simple things that we can do like checking heights over time on physical exam and looking for other shoulder asymmetries and other things that might indicate a potential problem, and ensure that all of our patients get lifelong follow-up when they do have scoliosis or kyphosis. That includes every 6 months when the patient is growing, and every year through age 25 and after each pregnancy, and then every 3 to 5 years thereafter. The main reason for this is that although sometimes we do see rapid curve progression during adolescence, that seems to level off when they're done growing. Some patients will continue to progress, and actually more than half, 68%, will continue to progress. And this can lead to a precipitous drop in quality of life later in time. And so having those curve measurements over time, combined with examining somebody's quality of life, can really help guide patients in making their best choices. The bottom line is that life is the long road. The average lifespan now is over 80 years, some living well into their 90s. So let's say if you could live to 100, if we think about that as like a marathon, 26 miles, basically when you're done growing, you're really only in Framingham on your way to Boston. And so it's hard for us to predict how the rest of your race is going to go for the rest of your life. And we need to make sure that your spine lasts you a lifetime so you don't end up with a poor quality of life later in life. And often a stitch in time can save 9, whether it's bracing or less invasive surgery or other conservative treatments. And from my experience, taking care of patients of all different ages for the last 20 plus years, from little children through adolescents, younger and older adults with deformity, I've learned a lot about how scoliosis and kyphosis can affect along the entire life journey. And that life journey experience that I've had even with some of my older patients helps me then to counsel some of my younger patients to know what really lies ahead, almost like a time machine. So why do we even care about spinal deformity? Well, we know there's different types: scoliosis, kyphosis, spondylolisthesis, and it can impact on quality of life with limiting activities, pain, disability, reducing respiratory function in severe cases, or diminished self-esteem. And we're thinking about lifelong quality of life. There's a big emphasis on prevention future suffering, preventing future deformity. The causes are often idiopathic, which means we don't really know what causes it, also congenital, neurologic, from cerebral palsy and other neuromuscular diseases, and degenerative, which we see on top of a lot of adolescent scoliosis very often later in life. We do know there's a genetic connection to it, but it's complex. Females obviously are much more likely to get it than men are, but if a guy does get scoliosis, they're much more likely to pass it on to their kids. So why do we care? Well, we want to maintain and restore quality of life, pain, walking, activities of daily living. We're also concerned about people's posture and appearance. And it doesn't matter what age you are, but that does matter to people, whether you're going through middle school or high school or as an adult, that we want to make sure that people feel confident about their self-image. And that can be affected greatly by their posture. And we also want to prevent curve progression later in life. So one analogy that often works well, especially when talking to other orthopedic surgeons, as I did for this grand rounds that I gave yesterday, is the whole importance of alignment. And we know that for example, in knee arthritis, that if we have asymmetric loading of the joint with either varus or valgus deformity, that can lead to asymmetric degeneration, which leads to more deformity in this vicious cycle that then can lead to early destruction of the joint. And so, as on this AAOS website, the idea of doing an osteotomy or taking out a wedge to realign that joint can lead to a dramatic improvement in the life of that cartilage and hopefully delay or prevent the need for a knee replacement. Well, what about the spine? In the spine, we just don't have one joint like a knee, but we have multiple joints, over basically 17 different joints stacked on top of each other, including 17 cartilage discs, 17 pairs of articular facet joints. And this can lead to basically what's called a buckling effect, where the effect of a collapse at one level can affect the adjacent levels and can then affect the whole spine. We also have the issue that we also have the adjacent spinal cord and nerves that are right with the spine, so we have that pain that can also occur, which we don't have as big an issue with a knee or hip replacement or knee arthritis. And we don't have the great backup plan of a joint replacement like we do for knees and hips. So this whole same thing with this asymmetric disc loading leading to asymmetric degeneration with asymmetric deformity, leading to this vicious cycle, which can lead to joint destruction and progressive deformity. So in terms of the etiology, the biomechanics and cartilage physiology, 68% of patients with adolescent scoliosis will continue to progress even after skeletal maturity due to this loading. The proteoglycan matrix can break down, then you can get some cell death, and then it's not producing the proteoglycan as well. You get the dehydration and then this ongoing progression. Whereas if we catch it early, we can either through bracing or earlier surgery to realign it, we can hopefully help those discs to last more of a lifetime. Good example of this on the far left, we see a slide from Lafarge at the SRS meeting 2014, where they studied a group of adolescent patients and looked at their MRIs before and after scoliosis surgery, showing that before surgery, many of these teenagers had evidence of early disc damage with degeneration, and from 3D analysis of the discs could actually show that they were starting to dehydrate even as a teenager. And by correcting the scoliosis, they found that the discs actually improved in their disc health, which is awesome news, that we actually even reverse some of that early change. On the far right, we see a 53-year-old gentleman who did not get his scoliosis fixed. When he was a teenager, his curve progressed to 90 degrees, and now you see his lumbar spine is completely worn out, and now he's really can't work anymore on the riverboat, and he needs a much bigger surgery than he would have needed if it had been addressed earlier in life. So if we can prevent that damage, that's much better for the patient in the long run. One of the things we also notice is that physics do act on the spine, and that if the patient is out of alignment, meaning pitched forward with kyphosis, or pitched over to the side with a coronal imbalance, that can lead to a force vector that wants to keep pushing the patient in that direction, almost like the Leaning Tower of Pisa. The further the Leaning Tower of Pisa was leaning over, the more force there was to keep wanting it to go in that direction, and that mechanical loading can accelerate that degeneration and collapse of the disc, resulting in greater deformity. So in terms of the nerves and spinal cord, the fact that the spine is right next to where the spinal canal is, that does lead to potential impact on the nervous system, because there's this reactive bone that causes osteophyte or bone spurs, and the discs tend to settle and bulge or herniate, and that can encroach into the spinal canal. In addition, in some cases, if the spine is tilted quite a bit, like in the lower lumbar area, people will get a side slippage or spondylolisthesis, or an anterior slippage, and that can also compound the nerve pinch, causing leg symptoms or spinal claudication, difficulty standing and walking. The ligament gets thick, the capsules get thick, and encroach into that as the body is trying to hold the spine up, and it's creating that reactive tissue. So although the degenerative changes could plateau, often these degenerative changes can continue to worsen and cause radiculopathy or sciatica and or neurologic claudication later in life. So why do we care about it during childhood and adolescence? Well, obviously, early detection can lead to earlier bracing, which is a possibility for some patients when appropriate. But hopefully that can also then help prevent later scoliosis collapse, either with bracing or earlier surgery, but also begin the lifelong follow-up process to make sure that we have good data over time. This is a study from the New England Journal of Medicine from Stu Weinstein that did a very large, did a prospective randomized controls trial within the past few years, where they actually showed that the rate of treatment success was 72% for the brace group and 48% of the observation group, showing that the brace does have some effect. But the problem is the end point of this study was just to skeletal maturity, which is basically around age 18. And so can we truly measure success at the age of 18? We don't have a lifelong scoliosis bracing study done. It would be too hard to do. And the bottom line is the race isn't over at mile marker 5 on a 26-mile race. So in this case, we're really just looking at success, by Framingham, but we need to get the patient all the way to age 100, which is Boston, And some of those braced patients do continue to progress later in life, so we can't guarantee that they are not going to have issues later in life, even if they were successfully braced and called a success at the end of skull maturity. So from my over 20 years experience caring for children, adolescents, younger and older adults with deformity, it's basically been like I've been in a time machine where I've seen the 15-year-old, the 25-year-old, the 35-year-old, all the way up to the 95-year-old with various spinal deformities. And that experience over the whole race, the whole long road, has allowed me to provide some wisdom for some of the younger patients to know what could be happening down the road, since they don't have a time machine to know what's going to happen in the future, and if there are preventive steps that could be taken to at least know what your options are. So how do we actually screen for scoliosis? Well, as for adolescents and for adults, we can use a scoliometer. This is just an example of one on the right, where it's actually a tilt gauge that you put over the thoracic and lumbar spine, and it reads off a number. If the number is more than 5 degrees, it's often indicated to get an x-ray, because that usually means there's a scoliosis at least over 10 degrees. You can also look for trunk shift or asymmetric hourglass, or a crease below the rib cage is a sign of that coronal imbalance. Obviously for kyphosis, if they're bent forward, you can look for that. Looking for shoulder asymmetry, and in adults, height loss is a very good marker for progressive spinal deformity. So other things we look for, as we talked about the height already, in terms of HPI and past medical, asking about childhood or adolescent deformity. If they do remember their old Cobb angles, that's great. Or if they have old x-rays, that's really awesome if they bring those in. And their perception of change of their deformity over time. Leg length discrepancies are also very important, whether they're actual leg length discrepancies or apparent leg length discrepancies, which is where the scoliosis is actually causing it to be an apparent leg length discrepancy. Sometimes patients will make up for that with a shoe lift. Past surgical history is important if they've had previous spine surgery, especially laminectomies or fusions, because laminectomies, especially in the face of scoliosis, will sometimes lead to further progression and failure through there. And fusions can also lead to adjacent level failure in some cases. We ask about red flag signs, which are signs of neurologic involvement. There's 5 of those: progressive bowel or bladder symptoms, motor weakness, numbness, clumsiness, or radiating leg pain. Axial versus radicular pain, that means is it the back or buttock that hurt, or is it more of the leg or sciatica type pain? And we also ask about how long they can stand and walk, and whether it's painful for them to change positions, like getting up and out of bed, which can be painful for some patients with deformity. Often patients with progressive scoliosis will have more difficulty standing and walking. In terms of the natural history, the large majority of them do well, but some patients will progress. The larger curves at the time of skeletal maturity, like over 50 degrees, are more likely to progress. Once the lower curve starts to collapse, the lower curves, the lumbar curves, can progress more quickly because it doesn't have the rib support. The research does support that degenerative changes are a primary cause for degenerative adult spinal deformity compared with vertebral modification due to osteoporosis. So it's really the joints themselves that are breaking down rather than the bone. Although in severe osteoporosis, you can get especially progression of kyphosis. And the key thing here is that spinal deformity is a chronic disease and requires the lifelong radiographic follow-up over time, and also assessing their quality of life. In terms of screening in adults, what's recommended is basically to follow people every 6 months while they're growing, every year through age 25 and after each pregnancy, and every 3 to 5 years thereafter. Degenerative scoliosis is common, over 30% of the adult population, and low back pain with scoliosis can be treated conservatively like other patients. We recommend using a low back brace, like an aspirin brace, anti-inflammatory medications, weight loss, core strengthening, often with some physical therapy help, and aerobic activity, all used together as a level 1 treatment. Stable curves can become unstable later in life if the joints start to break down, so we can never say that it's absolutely guaranteed that it's not going to progress. And the height and x-ray measurements over time are very helpful, and it is possible to get deformity after fractures. So you could have initial scoliosis or kyphosis, and then if the patient gets a fracture, then that can lead to a deformity, or even just an initial fracture can lead to either a scoliosis tilting to the side or a pitch forward, and those can progress even over a few weeks. We also can sometimes see deformity above or below old fusions, things like flat back syndrome, below a previous Harrington rod fusion. That can cause a patient to be pitched forward, and some of those patients need extension fusions later in life. So we don't want to be guilty of scoliosis misnomer number one, which is you're done growing, so you don't have to worry about curve progression. About 68% of people will progress, and that's something that we should encourage our patients to follow up on throughout their life. Kyphosis is something that we also treat and need to keep an eye on. Kyphosis is a forward tilt. All of us have kyphosis to begin with. Typical thoracic kyphosis is 30 to 45 degrees. We typically don't worry about it until it gets over 60 degrees, where it could become symptomatic. I still recommend conservative therapy for most of those patients. Over 70 degrees, especially if it's symptomatic, we can do surgery to help correct that. And often that's associated not just with pain over the hump, but pain in the other areas that have to compensate, in the neck area and in the low back area. And we follow it just like scoliosis with Cobb measurements. It also can be post-traumatic or post-op complication with something called proximal junctional kyphosis or distal junctional kyphosis. So Scheuermann's kyphosis is a common type of kyphosis that we see, especially when kids are growing, where the growth plate is actually growing abnormally at several levels, and that can dramatically affect people's posture. Last week we fixed a 14-year-old with a 90-degree Scheuermann's kyphosis, and he actually gained 4 or 5 inches with his surgery. Bracing really doesn't seem to help very much for kyphosis as it does for scoliosis, and physical therapy and home exercise can be helpful, but it can have a huge effect on your self-image and posture. This patient on the far right, a teenager, she really had a transformation of her personality after we fixed her kyphosis, and it really helped her getting through high school, feeling much more confident about her posture. In the bottom left is a patient of mine from Chicago that really wrestled with her self-image. She felt like she looked like a turtle throughout her whole life, and it affected her choices that she made. But she also then suffered with severe neck pain and lower back pain with several normal cervical MRIs. But when we finally fixed her 90-degree kyphosis, her neck pain actually went away because her neck had to compensate for that huge hump, almost like she was looking up at the ceiling. So spondylolisthesis can sometimes give fairly dramatic deformities. This is a patient that was treated elsewhere who had almost like a spondyloptosis, meaning the L5 vertebral body was tilting right over the top of S1. And so that's something else that we sometimes see and sometimes needs surgical treatment. This patient had a revision and did very, very well. The bottom line is we're trying to do what's best for the patient in the long run to maximize their quality of life. This is a picture with me where the patient just happened to drop in 10 years after she had her scoliosis fusion done as a freshman in high school. And she's pictured on the wall there on top of a pyramid where she was post-op after her scoliosis was fixed in high school. She actually went back to school within a week after her surgery, went back to cheerleading practice, and her mom actually brought in a video of her at cheerleading practice doing some moves. So our patients are able to get back to life pretty quickly, but they're also doing very well in the long run. And in her case, her lower 3 discs are now in good alignment below her fusion, and she also has an excellent posture and still very thankful. Older patients can also benefit from surgery. This is Marcia Del Barone, who wrote a good book called Curved Inspirations. When she had her large right thoracic curve fixed in her 40s and was able to return to a very active lifestyle, including doing some exercise running and running in some actual races. Other patients have had fairly dramatic improvements as well. This young lady, 24-year-old, was born without a left lung, was sent to me by one of my fellow surgeons here at Duke Raleigh, Chris Brown from Duke, and she had about an 85-degree curve that was progressing, and that was affecting her lung volume on her one good remaining lung. Plus, she had severe pain, could not really play with her young son, and it was affecting her quality of life at home. And so we did a surgery for her and preserved that and improved that one good remaining lung. And now she has an excellent quality of life, enjoying her family once again, and a good long-term outlook. My next patient is from Houston, Texas. Both her and her husband are physical therapists, triathletes, and she had a thoracolumbar scoliosis that progressed since her adolescence and had increasing difficulties with quality of life to the point where she really couldn't exercise much at all, and that was very, very important to both her and her husband. And with both back pain and radiating leg pain, we can see in her MRI she's developing a little bit of foraminal stenosis there, and that's there's also a dynamic effect of that due to her curve shifting as she's trying to run. And so she had a short fusion done for this, T10 to L3, and back in May last year, and had a very good road to recovery. This is her and her husband before they head back to Houston. And basically, pretty early on, she got back to walking 4 to 5 miles a day, during the first 3 weeks, and then she kept advancing that up, getting back to the gym with walking, core strengthening, and so on. And then by 6 weeks post-op, she was doing 6 miles uphill on the treadmill, and then then began to advance up, doing a 10-mile race at 5 months. And here she is running along and actually had a very respectable time of 1 hour and 23 minutes. No back pain, no leg pain, and her daughter got a chance to race in a small race that day as well, so she's enjoying her family more. So we were able to reverse some of that asymmetric loading and the asymmetric degeneration, getting her some symptomatic relief, but also then helping preserve that function below her fusion and allow her to get back to a good quality of life. 7 months post-op, this past January, she actually attained her goal of running the Houston Marathon, where she had a very respectable time of 3 hours and 35 minutes, no back pain, no leg pain, husband and patient very thankful. So life indeed is the long road, and we're trying to, I think I've learned a lot in the last 20 plus years of training in both in pediatric orthopedics and adult spine. And I think that by having that long-term view, we can help counsel our patients even early in life to maximize their spine function and help that one spine that we are given to last a lifetime. When you have a car, you can get multiple tires for your car, and you can get 9 or 10 sets of tires during your lifetime. But even there, you know the importance of keeping your car in good alignment to maximize the mileage. Well, for your spine, you only get one spine, and so we got to make those good years last a lifetime so that you can enjoy an excellent quality of life. Not just now, but through the whole marathon of getting you all the way to the finish line. So lifelong scoliosis care definitely has its benefits. It's really been a joy for me as I continue to serve in this area to see patients of all different ages benefiting it from a self-image perspective, but also from a quality of life perspective and preventing problems before they occur. And so the take-home message again are that we do need to talk more about scoliosis. Scoliosis awareness has gone down in the last 10 or 20 years now that scoliosis screenings are no longer done in schools. So I think it behooves us as physicians, other mid-levels, to basically do what we can to make patients and families more aware of scoliosis, to maximize their quality of life, and to keep it that way for their whole life. And just ask some simple questions about height and check things on physical exam, and try to help people ensure lifelong follow-up every 6 months when they're growing, every year through age 25, and then every 3 to 5 years thereafter, to have that data that we need so that we can help patients to make good choices down the road. Thank you so much for your attention, and if you have any questions, please do not hesitate to contact me here at Hay Clinic. Thank you.